The topic of today will be Introduction to Rheumatology and Introduction to Rheumatologic Disorders. This is a lecture which will be included in more than one part, and we are going to be covering the introduction first, and then we will discuss the basic anatomy, classification of rheumatic diseases, and how to investigate a rheumatic disease, and then we shall speak individually about specific rheumatologic disorders, rheumatoid arthritis, systemic lupus, scleroderma, and the spondyloarthropathies. Now, when we speak about the rheumatic diseases sometimes are called connective tissue disorders, and they usually manifest with generalized or localized inflammation, which means that the prominent feature of any rheumatologic disease is pain. And frequently, this pain is associated with systemic features. In other words, rheumatologic disease, they don't present only with pain of the involved joint, but commonly they are associated with systemic features like weight loss, fever, and usually in addition to the musculoskeletal symptoms, they are associated with extra musculoskeletal features. And the reason for this is once we understand that the rheumatologic diseases are called the connective tissue diseases, and if we understand the basic facts that the connective tissue, actually it is the most abundant tissue in the body and it is widely distributed in more than one system. Let's have a look here on this table. This table, it represents the diversity and what are the places which actually contain a connective tissue. You will see here that the connective tissue is present in the adipose tissue, it is present in the basement membrane, the bone, the cartilage, the dermis or the skin, the tendon, the visceral trauma or the viscera, and the vessel wall. So if you are talking about the connective tissue disorders in which the connective tissue is the target for the inflammatory process, so the inflammatory process might involve all these organs, which explains the fact that many of the connective tissue disorders, the symptoms are not limited to the joints, but they also involve systemic features and extra musculoskeletal organs. Now, these connective tissue diseases are extremely common and the treatment is costly and expensive. And these disorders actually they can present in more than one way. They can present in an acute manner or subacute manner or chronic manner. And because of the prominent feature, which is pain, sometimes this pain, it interferes with the daily activities, and the patient who are having exacerbation or activity of the musculoskeletal disorders, actually they are incapacitated and they are incapable of performing their usual daily activities. Now, we come to the classification of the rheumatic diseases. We classify the rheumatologic diseases according to the pathogenesis. In other words, there are certain types of rheumatologic diseases which are characterized by degenerative process. And the prototype for the degenerative category is osteoarthritis. And we have other category which is characterized by the production of immune-mediated or autoimmune antibodies, a category which we call it the systemic autoimmune diseases. The prototype is rheumatoid arthritis and systemic lupus. Another unique category which is called seronegative spondyloarthropathies. Seronegative, it means that the rheumatoid factor in this entity is negative. Spondyloarthropathies, involvement of the axial skeleton is a common feature. And these seronegative spondyloarthropathies, they include ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. And then we have a very big entity of rheumatologic diseases, which we call them the vasculitic syndromes or the rheumatologic diseases characterized by vasculitis, which is inflammation of the blood vessels. And according to the inflamed or according to the size of the inflamed blood vessel, we subclassify them into large vessel and medium-sized vessel and small vessel vasculitis. And finally, we have a category which is characterized by inflammation like the crystal-induced arthritis, and we shall speak individually about all these entities in detail. There is another way to look at the various categories of the musculoskeletal diseases in which we observe them or we classify them in another way based on the pathology. Now, There is an entity of the musculoskeletal disorders in which the target tissue is the synovial membrane and the hallmark of the disease is synovitis. The prototype of this is rheumatoid arthritis. We have another entity in which the inflammation primarily it involves what we call the enthesopathy. What is enthesopathy? Enthesopathy, it is the area of the junction between the tendon or the ligaments when it is inserted into the bone. So the enthesopathy are a group of diseases characterized by inflammation of the junctional zone which connects the tendon or the ligaments with the bone. The prototype for this is ankylosing spondylitis. And then we have another entity which is called crystal-induced synovitis, in which the synovial membrane is inflamed in response to the position of certain crystals. The prototype for this entity is gout. And then we have an entity which is characterized by infection or inflammation of the joint space. The prototype is septic or infectious arthritis. And then we have an entity which is characterized by cartilage degeneration. The prototype for this is osteoarthritis. And then we finally have an entity which is characterized by inflammation of the skeletal muscle. The prototype for this entity is the disease of polymyositis. Let's review the basic anatomy of the joint. We have three major types of joints, three major anatomical parts or anatomical types of joints. We have the synovial joints, we have the cartilaginous joints, and we have the fibrous joints. The synovial joints are characterized by a very wide range of movements. The cartilaginous joints, it is slightly mobile joint, and an example for the cartilaginous joint is the vertebral bodies of the spine. The only example for the fibrous joint is the skull suture. Now, we need to discuss more details about the synovial, which is the commonest types of joints in our bodies. Now, let's have a look on the basic anatomy of the synovial joint. The synovial joint, we have two bones, and these two bones, they are not in direct contact with each other, but they are covered here by a cartilage. The function of the cartilage is to diminish the friction which is produced by the direct contact of these two bones. The synovial joint is lined by a synovial membrane. This synovial membrane is filled with a small amount of synovial fluid. And as you can see here, one of the very important aspects of the basic anatomy of the synovial joint, it is strengthened by a fibrous capsule, and it is usually strengthened by surrounding groups of muscles. And this diagram, it represents the basic anatomy of the cartilaginous joints and finally the fibrous joints. According to the shape of the articulating surface of the synovial joints, we further divide the subnovial joints into three subtypes. The first subtype is called ball and socket entity. The classic example for it is the shoulder and the hip. The other type is called hinge joint. An example of the hinge joint is the elbow joint. And then we have another entity which is called the condylar category, and example for the condylar category is the knee joint. So the subtypes of the synovial joints: ball and socket, hinge, and condylar. This is a diagram which represents the ball and socket, and we can see here clearly the shoulder joint, and this is the hinge joint, this is the elbow joint, and finally we have the condylar joint. A classic example for the condylar category is the knee joint. This is a very nice diagram which represents the normal anatomy of the synovial joint. We can have here, this is the bone, and we have here, each bone is covered by articular cartilage, and it is lined by synovial membrane filled with the synovial fluids. According to the site of the inflammation of the different parts of the synovial joint, we categorize the pathology or we translate it into a disease. So if the inflammation is involving the muscle, we get myositis, and the prototype is polymyositis. Or we can have what we call the degenerative process, and this degenerative process might involve the cartilage, and the prototype for this is osteoarthritis. Or as we mentioned, we can have an inflammation in this zone. This zone, it is the area of attachment of the tendon or the ligament to the bone, which we call them enthesis or enthesopathy, and the prototype for it is ankylosing spondylitis. And finally, what we might have the primary target for inflammation is the synovial membrane itself, and the prototype for this is the rheumatoid arthritis. Now, we come to the topic of how do we investigate a patient presenting with a rheumatologic disease. We divide the investigations into three main categories: laboratory studies, and then an invasive procedure in which we get a sample of the joint effusion fluid, and this is an invasive method, and finally we have the imaging studies. Now, when we speak about the laboratory studies, what are the different laboratory tests that we can use to investigate the rheumatologic diseases? The laboratory studies include, number one, markers of inflammation; number two, the rheumatoid factor in itself; number three, we screen for the presence of antibodies or autoantibodies; and finally, when we do an invasive procedure to aspirate the joint fluids, we will subject it to laboratory investigation. Now, markers of inflammation. What is meant by markers of inflammation? Now, the immediate normal body response to any kind of inflammatory stimuli is the production of what we call acute phase reactants. These acute phase reactants are various types of proteins which are primarily produced by the liver. And the liver produces these acute phase reactants in response to what we call cytokines. The cytokines is a very big entity of chemical substances which are primarily produced by the macrophages. So the macrophages produce various types of cytokines. These cytokines will act on the liver to produce more than one type of proteins that we collectively call acute phase reactants. And these acute phase reactants, or increased production of certain proteins by the liver, these are responsible for example, we have an example of acute phase reactions is the C-reactive protein, and another test which reflects the production of acute phase reactants is the elevation of the erythrocyte sedimentation rate, and also in response to the release of cytokines, we might have leukocytosis and thrombocytosis. So C-reactive protein, elevation of sedimentation rate, the presence of leukocytosis or thrombocytosis, all these are markers of inflammation. Now we come to the second item that we usually ask the labs to do it when we are suspecting or when we are investigating a case of rheumatologic disease, which is called the rheumatoid factor. What is rheumatoid factor? Rheumatoid factor is a kind of immunoglobulin, and rheumatoid factor, it was found that it is present in 80% of rheumatoid arthritis. Pay attention here that rheumatoid factor is not present in all cases of rheumatoid arthritis, and it is present only in 80%. And the rheumatoid factor, its presence in case of rheumatoid arthritis, it is usually associated with an aggressive disease with a bad prognosis. Now the question is, this is called rheumatoid factor. Does this mean that it is restricted or it is specific for rheumatoid arthritis? The answer, no. Now this is a partial list which shows that the rheumatoid factor, it is present in more than one disease. In addition to the rheumatoid arthritis, we can have cases of systemic lupus, systemic sclerosis, Sjogren syndrome, polymyositis, in which we will find a positive rheumatoid factor. Rheumatoid factor, even it can be present in certain infections like bacterial endocarditis and tuberculosis, and it can be positive or present in certain pulmonary diseases like sarcoidosis or interstitial pulmonary fibrosis. So rheumatoid factor is not specific for rheumatoid arthritis. Now, another category of immune or of laboratory tests that we frequently screen when we are suspecting a case of rheumatologic disease is anti-nuclear antibodies. In certain immune-mediated or in certain connective tissue diseases, there is increased production of autoantibodies. These autoantibodies are directed against various components of the cell, including cytoplasmic contents and nuclear contents. And these antibodies actually, they might be targeting in nuclear components like antibodies against DNA or RNA or other nuclear or cytoplasmic agents. And this table is a very nice table, and it shows certain rheumatologic diseases and the commonly encountered autoantibodies which are present in them. For example, drug-induced lupus, it is characterized by the presence of antihistone antibodies. And most cases of systemic lupus, they have a positive test for anti-double-stranded DNA. And a very specific antibody for systemic lupus, it's called anti-SM or anti-Smith antibody. And in Sjogren syndrome, we will find another autoantibodies which is called anti-Rho antibody. And in cases of progressive systemic sclerosis or scleroderma, you will find autoantibodies which is called anti-SCL70. And in certain cases of polymyositis and dermatomyositis, you will find a specific autoantibodies which is called anti-Jo1 antibody. So it's a good thing to remember these autoantibodies, because according to the rheumatologic disease that you are suspecting, you will know which antibody screening test you shall be using. Now, regarding the joint fluid analysis, in certain cases, you might have certain rheumatologic diseases associated with joint effusion. So it is quite logic that you insert a needle and you take part of this fluid for analysis. And usually we encounter this situation in what we call acute monoarthritis, because usually the effusion is limited to one joint, and acute monoarthritis, it has specific causes, and one of the very important diagnostic tools in the laboratory assessment of acute monoarthritis, which is acute inflammation of one single joint, is to aspirate this fluid and you subject it to analysis. And according to the nature of the aspirated fluid, we divide this aspirated fluid according to its nature into non-inflammatory, inflammatory, septic, and hemorrhagic effusion. This is a diagram which represents the procedure of joint aspiration, and it's needless to say it should be carried out under complete aseptic conditions. You can see here whoever is doing this technique is wearing gloves, and this is a sterile syringe, and after putting local anesthesia in this area, you simply insert the needle and you aspirate. And you can see here that the aspirated fluid is bloody in nature. Now, according to the obtained fluids, you can have non-inflammatory aspirate, and this characterizes osteoarthritis. And actually, we have seen it that certain cases of osteoarthritis might be associated with effusion. Or you can see, like the previous slides, you can have hemorrhagic. Once you get hemorrhagic effusion, you should suspect it is either traumatic or tumor or tuberculosis. Or you can get an inflammatory effusion. Inflammatory effusion, we see it in cases of gout or septic arthritis or certain other cases like rheumatoid arthritis or systemic lupus. Now, we proceed into the imaging studies. An integral part of evaluating any rheumatologic disease is to do some imaging. Now, what are the various imaging techniques which are available in various rheumatologic diseases? Plain radiography, plain X-ray, the simplest and the cheapest, magnetic resonance imaging, ultrasonography, and computed tomography. Now, the radiography, which is a plain X-ray, this is the simplest, the cheapest, and usually this is the initial imaging techniques. And in certain cases, usually the treating physician doesn't need to do more than a plain X-ray. For example, sports injuries or anything like this, sometimes the plain X-ray will be quite enough to demonstrate any pathological problem in the joints. And this image, it represents a plain X-ray image taken for the knee. This is the femur, this is the tibia, and this is the patella. Now, the second important diagnostic imaging is magnetic resonance imaging. Actually, magnetic resonance imaging, it is the study of choice in evaluating most, if not all, of the rheumatologic diseases. The major privilege of magnetic resonance imaging, in addition to its superiority to visualize the bone, it is actually the study of choice to visualize the soft tissues and the muscles. The soft tissues and the muscles cannot be visualized effectively in the plain X-ray or even in the CT. So the major privilege of magnetic resonance imaging is that in addition to the precision and superiority in the quality of the image of the bone, it is quite accurate in demonstrating the status of the soft tissues, the muscles, the tendons, and the ligaments. And that's why it is quite effective when we are suspecting joint effusion or when we are suspecting tears or partial tear of any tendon or any ligaments, or if we are suspecting partial tear in a cartilage, because the cartilage, it is not properly visualized in the plain X-ray. This is an image for MRI of the knee, and I want you to focus here how precise and the resolution of the image. This is exactly as if we are watching an anatomy image in Gray's textbook of anatomy. This is the femur, this is the tibia, this is the patella, and this is the tendon. Can you see the tendon here? It's very clear. And this is the patellar tendon, and here this is the muscle. And that's why the magnetic resonance imaging, it's a fantastic, wonderful way for diagnosing all of the rheumatologic diseases. And I put this slide for you to compare now the quality of the plain X-ray here and the quality of the image in the magnetic resonance imaging. Ultrasonography, sometimes we use ultrasonography, which is non-invasive, less expensive, and we use it in certain cases. For example, if you are suspecting that there is joint effusion or if there is any problem affecting the tendon sheath. And the image here, and you see it here, this is an image for sonography of a knee ganglion. Now we come to the final imaging modality, which is computed tomography. Computed tomography, it has a peculiar advantage in demonstrating fractures. So most of our colleagues who are working in the orthopedics departments, in any case of trauma or car accident, actually this is the study of choice that they usually ask, which is CT, because it is very effective in demonstrating simple and complex fractures. In addition, there are certain joints which are actually very difficult to assess them properly on a plain radiograph. In particular, the sacroiliac joint, the temporomandibular joint, and the sternoclavicular joints. However, if there is a need to demonstrate any soft tissue in or surrounding the muscle, in this case, the study of choice will be the MRI. Remember, the major advantage of the MRI over the CT is its superiority in demonstrating the soft tissues. And this is an image for a CT of the cervical spine. It is a very clear and high resolution, but again, it is uncomparable to the high resolution obtained when we see an image performed by the MRI. This is the end of part 1.